Welcome back, medical coders, billing specialists, and students, to this clinical masterclass explainer. Look, if you've ever stared down a urology operative note and felt that sudden wave of panic over which lithotripsy code to pick, you are in the exact right place. Today, we're building a totally foolproof framework for lithotripsy coding. We're going to strip away all that confusion, lay down a rock-solid foundation, and make sure you can confidently assign the exact right codes. Because at the end of the day, we want to completely avoid those frustrating claim denials, right? Let's get into it.
All right, so here's our roadmap for today. We'll kick things off with approach-based coding logic, then dive straight into the 3 core lithotripsy approaches. After that, we'll cover common pitfalls and denial risks, introduce a lifesaver 5-question checklist, run through a quick interactive knowledge check, and finally wrap it all up with a summary and next steps.
Let's jump right into Section 1, Approach-Based Coding Logic, and the core rule you absolutely need to know.
Now, the treatment of urinary calculi is highly scrutinized by payers, and literally one misdetail leads straight to a denied claim. So, to prevent that, you really have to internalize this core coding rule. Code selection is strictly driven by 3 things. First, the surgical approach used. Second, the anatomical location of the stone. And third, whether extraction was actually performed. This right here is your aha moment. Simply put, if you don't know the exact physical approach the surgeon took, you simply cannot code the procedure.
So when you're reading through those operative notes, you're primarily hunting for 2 main invasive pathways. You need to ask yourself, are we dealing with an endoscopic retrograde approach? Passing a scope up the urethra and into the ureter to get to the stone. Or are we looking at a percutaneous tract where the surgeon enters directly through the patient's skin straight into the kidney? Understanding that distinct difference between going up the plumbing versus through the wall is basically your foundational anatomy for this.
Moving right along to Section 2, we'll be breaking down the 3 core lithotripsy approaches, ESWL, URS, and PCNL. All right, let's break down the big 3 approaches and map them to their CPT codes. First up, notice the complete lack of surgical invasion here. This is extracorporeal shockwave lithotripsy, or ESWL, and it maps straight to CPT code 50590. You can clearly see the external lithotripter beam doing the work. There's literally no scope entering the patient's body. It relies entirely on external acoustic shock waves focused right onto those renal or upper ureteral stones to just crush them. So, doctor on the outside, shock waves firing in, that's your 50590. Next up, we have ureteroscopy with laser lithotripsy, or URS, which pairs up with CPT 52356. Notice the ureteroscope here. This is exactly that retrograde access we just talked about. The scope is passed right up into the ureter under direct vision. Then, once the surgeon locates that stone, they're going to utilize a laser fiber, most commonly a holmium laser, to fragment the stone. And often this procedure also involves extracting those fragments, usually with a tipless basket, and then leaving a stent in place. So retrograde access plus a laser, that means 52356.
And finally, we have percutaneous nephrolithotomy, or PCNL. This maps to CPT 50080 or 50081 depending purely on the stone size and complexity. See the direct nephrostomy tract established here? The surgeon has basically bypassed the lower urinary tract entirely, going straight through the skin and muscle directly into the renal pelvis. Now this is a highly invasive approach, and it's reserved for massive stone burdens or those really complex staghorn calculi that simply are not going to pass down the ureter.
Okay, so here is your master blueprint, summarizing these 3 approaches. For those of you currently prepping for your certification exams, I absolutely urge you to just memorize this matrix. See how the clinical indication and the approach pair perfectly with a specific CPT code. External shock waves for those small stones routes straight to 50590. Endoscopic access for ureteric and renal stones routes to 52356. And that direct percutaneous access for large complex stones, that's going to route to 580 or 581. Once you master this table, you have honestly won half the battle.
Let's head into Section 3, Pitfalls and Denial Risks, or as I like to call them, the hidden dangers. Because textbook theory is great, but clinical reality is a whole different beast, right? Let's look at the hidden dangers lurking in poor physician documentation. For instance, missing the stone location or laterality, like left versus right, makes it basically impossible to finalize your code. But you know what the biggest trap is? It's when a physician writes down stone fragmented, but totally fails to specify if basket extraction actually occurred. Listen to me on this. Never, ever assume extraction happened if it isn't clearly documented. Coding an extraction without actual proof is a one-way ticket to a denial. Plus, if a ureteral stent is placed, that documentation must explicitly support its clinical context and medical necessity.
All right, Section 4, the 5-question checklist, which is basically your ultimate pre-coding weapon.
To really bulletproof yourself against those hidden dangers we just covered, here is your daily compliance tool. You need to systematically ask yourself these 5 questions for every single case before you even touch your code. 1. Where exactly was the stone located? 2. What specific approach was used? ESWL, URS, or PCNL? 3. How was the stone treated? Was it just fragmented, or was it fragmented and extracted? 4. Was a ureteral stent inserted? And 5. Does the operative documentation fully support medical necessity for the procedures performed? Print this out, stick it on your monitor, and make it your daily shield.
Let's move to Section 5, time for an interactive knowledge check, the trial.
Let's wake up those brain cells with some rapid-fire real-world scenarios. Here's Scenario 1. A 1.5 centimeter renal stone is treated with external shock waves. No scope was used at all. Take a quick mental pause, apply our core rule from earlier. What's the CPT code?
Got it? If you said CPT 50590, you hit the nail on the head. The absolute keyword here is external. External shockwaves mean extracorporeal shockwave lithotripsy, which we know is entirely non-invasive.
Awesome. Let's step it up with Scenario 2. An 8mm ureteral stone is fragmented. The energy source used is a holmium laser, and the approach is endoscopic under direct vision. Which code are we looking at for this one?
The answer is CPT 52356. Remember our blueprint. Retrograde endoscopic access combined with laser fragmentation, like that holmium laser, points directly and confidently straight to 52356 for laser URS.
Okay, let's combine our final 2 high-level exam challenges. First question, what code family do we use for a massive staghorn calculus that requires a percutaneous tract for removal? And second, here is the ultimate real-world problem. What do you do if the op note says the stone was fragmented, but it completely misses any details on whether it was actually extracted?
Let's break those down. For that complex percutaneous anatomy removing a staghorn calculus, you're looking right at PCNL codes 500080 or 500081, and you'll select between those based purely on the size of the stone. And as for those missing extraction details, your only move, your absolute only answer, is to query the physician before billing. Never, ever guess. As a coder, your absolute greatest defense against an audit or a denial is just stopping the line and asking the physician to clarify their documentation. Which brings us to Section 6, Summary and Next Steps. Let's wrap this up.
We've covered a ton of ground today, going from confusing anatomy to total coding compliance. So let's lock in our final takeaways. Always remember, lithotripsy coding relies strictly on matching that surgical approach to the stone's anatomy. Always use your 5-question checklist to catch missing details before they cause a problem. And coming up next in Part 4, we'll be mapping out the complex clinical pathways of prostate interventions, going all the way from diagnostics right through to therapeutic treatments.
Before we sign off, I want to leave you with a final thought to ponder as you look at your very next operative note. Are you just blindly documenting a list of procedures? Or are you truly telling the complete, accurate anatomical story of the patient? Because if you get the anatomy right, the codes will naturally follow. Like, share, subscribe to Decode Healthcare with Harshal.